speaker is Anne Hayward. Anne is a social worker, but officially no title, but she's much more than this. To the roster, she's basically psychologist, she is support, she's mom, she's everything. So basically her role is all-inclusive. And I think what Anne, what does all the wound care, what does all the survival mean without the social support, without the support that is needed for families? And, the burn has also an impact not only on patient, but also on the families. Do we ever think about how patient caregivers receive what we do? Anyway, so Anne maybe can elaborate a little bit on the management of all this, what it all means in terms of long term.
How do I use this?
And he has been doing burns for over 13 years. Yeah, you put this, just try to hold it somewhere. Or put it down here, wherever you like.
How do I advance?
Yeah, here, green.
Green, I have two, great.
Green is forward, red is back.
Okay. I have nothing to declare other than I hate public speaking, so I apologize. But I think this is really important that we talk about the psychological aspects of recovery, and not only in terms of patients and families, but also support of the caregivers and what we do, because there's not a lot of us out there who truly understand what the emotional toll can take for everyone else. And I've been fortunate to have a lot of great teachers in terms of colleagues I work with, as well as burn survivors and families themselves, one of whom has kindly allowed me to share some of his slides to try and personalize this a little bit, and his name is Ralph Walker. So the learning objectives, as I've said, is to try and understand things more so from a patient and family perspective. The family, I think, is often forgotten, to understand barriers to recovery as well as factors of resiliency. So imagine yourselves from now. We've heard Sarnia, I've heard Peterborough, where people are from, throughout the province, throughout Canada. Imagine your profession. Imagine being here right now, and if something were to happen in the course of this week here and you were injured, or your family was injured, and trying to deal with your life and trying to get back to people. So how do you get from this? Ralph, his wife Diane, their dog Bear, their 6-year-old son. From being a soldier serving a tour of duty in Afghanistan, not getting injured there, but always the threat and the risk, to then going on to being in an explosion like this. How come this is keep going? Sorry. We're going to go into some graphic photos of what's happened to Ralph in going through that explosion. So this was Ralph when he came to us from Sudbury on admission. Okay, we saw him before, his life before. This is him through some of the resuscitation. 2nd and 3rd degree burns to 75 to 90% of his body. Escharotomies. Numerous allografting and autografting surgeries that the doctors have talked about, what they have to do to save somebody's life. Painful surgeries, the meat hook photo, that they're not even aware that they've gone through, right? To be able to wake up to this, you can see the body changes in terms of that, to be able to be motivated to do this, to fight through the pain, to be able to hug your kid again, and to get back to your life. What does that take? What do we have to do to support that? What does it take for the individual? So a reminder, we know burns is, by definition, a trauma. It is something that is sudden. It poses risk to self or others in terms of life or serious injury, and or even witnessing it. There's a vicarious trauma that people also experience by going through and seeing something like this, or the double whammy of being a survivor but also witnessing another person's death or multiple injuries. This is something I learned in undergrad, which is really important. Everyone wants to jump to the finish line, get better, hurry up, faster now, and deal with the touchy-feely stuff. We're uncomfortable when people are crying or have an emotion, but they can't get to that higher level of dealing with emotions until we deal with the basics. It is survival mode one-on-one in terms of whatever their needs are, functionally, practically, getting through the surgeries. So there's a lot of delayed or deferred processing that cannot happen until they actually have the physical energy to start dealing with this stuff and their basic needs are addressed. So immediate emotions, again, going back to when Ralph was first injured and seeing his life before and after, a lot of the shock value in terms of what's happened for both patients and families. the thoughts of, am I going to die? Ralph actually made a phone call to his wife in the helicopter, organizing their affairs, but knowing he was saying goodbye. She had no clue. For her, it was just, what's happened? Is he going to be okay? The why me and how could it happen? A lot of emotions in terms of anger and blame and guilt and anxiety about what's going on. As the patient is feeling vulnerable or unsafe, the family is also feeling, how can they help? How can they fix things? What can they do? What is their role? With pain, families are also experiencing that helplessness in terms of how to help people. The loss also brings uncertainty. So a range of emotions that are happening simultaneously. In terms of hospitalization, it's not one phase. There are a series of phases that are happening within that. On admission, as I said, it's crisis support 101. What are the basic needs? What do they need to know? Again, even for family, what's happened? How do I pack up my life? How does Diane with her child, the dog, her work, living up north in winter, getting here to Toronto in terms of dealing with that? So what do they need? The assessment from a social work perspective becomes very important to understand what was that person's life pre-injury. So when the surgeons have talked about quality of life and the ethics in terms of would some people want to continue, would some people not want to continue, it sometimes helps us formulate how to motivate people in recovery, but also knowing what their quality of life was before and whether or not they actually would want to proceed with treatment. So the assessment also has to include mental health and addictions. That's a huge area with our population at risk and the choices that they make. There's a lot of secrets in terms of that aren't necessarily told to us in discussing with patients or families at the beginning, and they're revealed later on. There's cultural, gender, religious, spiritual dynamics that also can come into play. So the assessment becomes very important in terms of the foundation, I think, in terms of my work in helping and supporting people. Communication is really important. We need to connect the dots. What is the diagnosis, the prognosis, the context of the injury? What does that mean? We're really good in throwing medical terminology around, but where I come from, a flank is a side of beef. It is not a body part. Neither is a trunk. It's a car. So if you have people with language differences or differences in education, we have to make sure we're explaining it, but also connecting the dots. 20% burn, 30% burn, inhalation injury. What does that mean in the context of being diabetic or older, all those factors? We have to deal with expectations. People assume when people come to Sunnybrook, this is not a good thing, they're coming to the trauma center, or it's Sunnybrook, they'll take care of everything. So what are the expectations that need to be addressed in terms of course, the person will survive or not? How are we addressing that? And my role at that point is information, counseling, support, a lot of education, and trying to facilitate communication. You know, we joke about having 4 different surgeons and many different approaches, but we also need to have some continuity in terms of what we're saying in the messaging and understanding what that is. So throughout the length of stay, we know on average it's a percentage, 1% per day is how long people stay there. But people get into the false sense of security that the longer they are here, that it's a guarantee of survival, which we know it is not. We prepare people for the fluctuations and ups and downs, and it's okay, but people panic in terms of that. So we have to explain to them what we are expecting and not be dismissive and saying, don't worry, but really worry when we are worried, because there's a natural kind of aspect of the burn care and the trajectory. Expectations are always having to be addressed in terms of trying to get people, when will they be better? When is the magic moment that they will no longer be at risk? What will that look like? The time warp, I think, is important. If you think of Ralph being on the ventilator and all the treatment he's gone through, his family has lived through all of that and the ups and downs. He wakes up however many weeks later. He cannot catch up to where families are. So families and everyone else has to dial it back, and now he has to go through that as the patient and trying to catch up and understand. And that's very difficult for families who want to spare the pain, but they also then are reliving that pain vicariously through their loved one going through that. Practical realities hit home a lot more at this stage in terms of, maybe, Bradley, he needed mom back home. And guess what? It was Christmas. Santa still comes for a 6-year-old boy. It doesn't matter if dad's in the hospital. Financial realities. We are very lucky to have OHIP and socialized health care, but there's things that aren't covered like hotels and parking and transportation. And not everyone has the resources to be present to support people. And not everyone has caregivers. Some people are very isolated and alone for many reasons, especially with mental health and addiction. So they don't have supports, or this phase, the family support. They're getting burnt out, and the patient has more demands and isn't even aware of what the families have gone through. As they go through to discharge, patients start having voices, which sometimes is challenging to us because they can say no. They don't like things. They speak up. The transition of autonomy from back to the patient being empowered or trying to make sure they take on that role is important. So we start directing a lot of things to patients, whereby families start to feel excluded, or patients defer everything to the families, and we can't let that happen, or they won't get better. Families and people will feel sorry for the person. They will not get better. They will not advance. Coping, again, throughout this, the patient starts to experience more of that emotional aspect of recovery because they have the physical energy to do so. So the acute stress responses that could have also been present at the beginning in terms of flashbacks and sleep disturbances and triggers and all of that. This is the time that we monitor more closely in terms of risks of depression and for post-traumatic stress. Community reintegration. We're not sure. Sometimes some of our patients are going on to rehab, so I'll start a process, and my capable colleague at St. John's will continue. We have a lot of conversations about that, or we're preparing people to go home. And what does that mean to have visible scars or hidden scars? It's very different, having a facial burn and having to put your face out there every day. How do you deal with stares, pigmentation changes? How do you deal with wearing a mask in public or garments in public? What does that look like? So we're teaching people gradually. Our therapists are excellent. Getting out of the room, it's a safe, it's a burn environment. Going in the hospital, people are injured and ill. Well, what's that like going to the bank? What's that like going back to work? All of those things. We're also preparing people in terms of their relationships, the patient and caregiver relationship, and resuming whatever their pre-burn relationship was. Sometimes that wasn't great, but you cannot continue in terms of having that couple relationship, the sexuality and intimacy with somebody who's wiping your bum. So how do we talk to families about what that looks like in reintegrating the touch and the concepts of that? We prepare them also for next steps. Many people feel that once they leave hospital, it's all better now, or when will I get plastic surgery and be back to normal? And not realizing they've had surgery, they've had plastic surgery, and you will have scars to some degree. When people go to inpatient rehab, my social work colleague Ronnie has kindly allowed me to share these slides, and she says a different reality starts to hit in terms of the emotional transition and becoming one step closer to resuming their life, whatever that might be. So it hits people differently now that they're not so worried about dying, but figuring out how to live. Those pre-existing stressors that they've had, and it could be in terms of social determinants of poverty and health and financial issues and housing, as well as family relationships, all of those come into play a lot more now because they're one step closer to leaving hospital and having to figure things out. The mental health compliance and addiction compliance, everyone assumes that we provide an opportunity not to resume previous habits, but people don't always avail themselves to that opportunity. And so the choices and the factors that people make become much more important. The decision-making reverting back to the patient who can say yes or no. And so we have to sort of tap into, how do patients find that path? How do we support them in their path in terms of making choices and getting better to the best of their abilities? The connections with community stakeholders and community supports are really important for the continuity of care and community reintegration. For some going to outpatient rehab, so that could be directly from our hospital or the inpatient process, the grief factors that come into play a little bit more in terms of understanding the pre and post-burn identity, taking inventory of their injuries, who they were before, their abilities and disabilities, the stressors we spoke about. And I just want to talk about sexuality and body image a bit more, because we are awful as healthcare professionals in terms of addressing that component. There are side effects of medications that cause erectile dysfunction, vaginal dryness. There's issues in terms of positioning. The patients devalue themselves or feel that they are not worthy, and family members can be repulsed by the scars, or those who are intimate with somebody may actually be thinking, the scar is actually a painful reminder that somebody they loved went through something. And if we don't initiate that and have a forum for patients to be able to speak to that, then it's really hard for them to raise that topic. Preparing people for the world returning to work, very different if you've been injured at work. If you can't return to work, how do you sell yourself and have the self-esteem to be able to do so with visible injuries and burns or differing abilities? And what is your identity if you can't be a surgeon or you can't be that military person? Who are you? So how do you kind of tap into what's next? We've talked about acute and chronic wounds, and I just want to point out the one thing with acute wounds, they're short-term, and although they're painful, once patients start to see evidence of recovery, there is more hope. So they don't think this is lasting. With chronic wounds, it is very different. It is always a reminder of being stuck, not being able to go forward. And what some survivors actually tell us later on, and we're not always aware of it, they still think they potentially could die or they're at risk of amputation. So stages of emotional recovery, there's a lot of researchers and psychological and psychiatric journals that cover various stages, but in essence, there's 3 stages in terms of restoring safety, remembering, and reconnecting. And this is what we try to do to help facilitate that recovery. Reassuring patients that, although life was very different, those tangible risk factors, that sense of security that we take for granted has changed, they are now safe. So reassuring them of that. We know that it's hard to move forward in reflecting about things when they still have their physical needs that dominate, the pain that dominates. So as that progresses and we're trying to deal with that sense of safety and reassurance and hope even more, there's individual variables in terms of the patient themselves, how they cope with things, previous trauma exposure. So Ralph, that could have been a very protective factor. He's lived, seen, been through worse, or it could have been a tipping point for him in terms of other things that would have just pushed him over the edge in terms of something else he'd gone through. We talked about the accuracy of assessments, some of what I do on admission, but also for patients who may be thinking the woulda, shoulda, couldas, and what ifs, and if only this. We had at our burn survivor and family annual event a few weeks ago, a spouse had said, this totally sucked, but I look at it in a different way and say, if my wife hadn't been injured this way, I think it actually protected her from something worse that was going to happen. So how do we kind of tap into doing that mental Jedi of looking at things differently and looking at the perspective differently? We've talked about the acute stress response. Triggers are a protective factor in sensory stimulation of what people heard and felt or perhaps had smelt, in terms of warning them for other danger and telling patients what that role is when they're having panic attacks or anything like that, that they are not going crazy, that this is a stage of recovery that we're working through to help them regain control of their environment, regain control of themselves. They had no control perhaps over the event, but they do have control over what's happened to them. We haven't really talked too much about suicide, so people may have been in control of making some decisions in terms of that, but moving forward, they have survived. Is there a purpose in that survival? How do we support them? How do we try and tap into those things? And how do we help them regain some equilibrium? The remembering is very important, and you can start to see as people start retelling their stories a little bit more, that they become more composed. But initially, there's a huge avoidance. We don't like things that make us uncomfortable. We push things away. And I liken it to the tsunami effect, that the more we push things away, it will come back and hit us if we don't deal with that in a timely, effective manner. Fauerbach and others talk about getting used to cold water and using the analogy of dipping your toes into the cold water to gradually get exposed and used to things. And as you do, you're able to move further and further along in the process. But if you were stuck on the shore and only have your toes in the water, or don't take advantage of that, guess what? Other people are moving forward and life is going on without you. So I thought that was a good analogy. As people retell their story, their voice comes back. It helps give perspective to the event and what happened, and it helps to connect emotions and thoughts from being disconnected, to be quite honest, in those silos, to be able to integrate that together so they can acclimate. And I also don't think we give enough opportunities for families to be able to do that. They seem to be on the side or as an afterthought, and they may have very different experiences in terms of what that is, or not similarly not want to talk about it because it's not about them, or they want to protect the person that has been injured. With withdrawal, there's isolation. With engagement, there's those connections. So that restoration of hope is very important in terms of that process. And how do we help people to understand what their new norm, what their new life could look like, and what that sense of self and new possibilities. So barriers to recovery. Dr. Stephanie Mason, one of our residents, and others have done research in terms of this. They've talked about outcome and gender and level of education. We know the seriousness of the burn, sense of loss, and how debilitating it is, can have a negative impact. I'm always a bit hesitant with research that tells me females are more predisposed to having anxiety and PTSD, and I just throw it out there because I think sometimes it's more socially acceptable for women to be able to come forward and say they're having difficulty in coping, and I don't know that men feel as comfortable and confident in doing so. Level of education can be an impact, and again, I wonder if, the possibilities of what their life may be like may be limited based on where they are in life, and if that's taken away. Avoidance, people who are avoiders, people who are A-type personalities and resistant to change, those are very difficult for people to move forward and adapt. People who won't accept help or recognize they need help even when other people are telling them that. So people who are angry and pushing everyone away, you will be alone. That's what will happen unless they start to take some responsibility for themselves in their recovery. We can't work harder at it than they do. They have to invest and buy in at some point. The mental health and addiction issues is something we struggle with quite a bit in terms of, trying to look for opportunities for change, but what lifestyle choices do people want to make, or if they're going back to the same social circumstances. The burn is unfortunately another blip in the traumatic lifestyle that they leave, and there'll be something else and something else. The social determinants we spoke about. If you've had crappy housing and no money before, now you're burned, or if you've had all these health issues and you're more debilitated, now what? So in terms of resiliency, the life experience that we talked about, and sometimes I think generationally we're missing some of that in terms of, we don't want to go overboard in terms of the sucking it up and toughing it out, but how do we promote some resiliency along the way, as opposed to people can't fail anymore and everyone passes. The acceptance of what is and isn't in people's control. Again, we can control our emotions and our response. How do we help people process that when they had no control over what happened? Healthy choices in terms of food, diet, exercise, their routine and sleep are very important with any health issues, but also if they're not doing that, it affects the chemical imbalance in their brain, and they can isolate themselves more from other social opportunities, and they're alone and lonely. Getting help, speaking up. We're not mind readers, neither are families, and sometimes people don't communicate well at baseline or in newer relationships. How do we help people to communicate how they're thinking, how they're feeling, what they need? Symptom management, the itchiness, the pain, lack of sleep, they are crazy making. And again, to the hierarchy of needs, if we don't look at interventions around those things, or sometimes medications, they can't talk about their feelings or dealing with anything else. It just hurts and they're itchy. Social skills, preparing people for going out in public, the steps that they need to talk, how do they empower themselves to control a situation if people are staring or talking, and the role of psychotherapy in terms of CBT, stress management, relaxation techniques, and counseling for people, especially those who are at risk in terms of the PTSD and depression. I think that we need to look at mental health being more integrated in terms of the care. Not everyone will fall apart. People do get better. There's post-traumatic growth. That's talked about in literature, and one of our former colleagues, Judy Knighton, speaks a lot about that. People are resilient. The natural tendency is to try and push through. So how do we support them in doing that without neglecting the fact that there will be people who are at risk that we need to provide the support to? And I think that we also need to make sure that we're looking for opportunities for families to be able to also participate in that process, because right now that's a separate silo. For Ralph, he's still married. His son towers over me now. He's in his second year of university. Ralph was no longer able to be with the military. He was blind in one eye from some of the pressure changes when he was injured, but he passed every fitness test, I think sometimes in defiance of pushing himself through and proving he can do himself. He's teaching at a college in terms of carpentry and other trades, and he does home renovations, and it's not easy. Sometimes he wonders if the aches and pains are the burn, but he also feels it's too easy just to blame the burn, as he recognizes he's 12 years older too, and certain things start to affect us differently at that age. There's a lot of resources from the Phoenix Society and different psychologists, KMH in terms of burns or trauma and coping, and thank you.